Welcome, everyone. My name is Colin Busby, Research Director of the Faces of Aging program at the IRPP, and I'm broadcasting to you today on the Indigenous lands known as Tiohtià:ke, Montreal, an area historically known as a gathering place for many First Nations. Our downtown offices are located close to a number of Kanien'kehá:ka Nation communities. Thanks for joining us today to talk about options to expand home care in Canada. We have a wonderful group of experts on our panel today, and I'd like to take a moment to briefly introduce them. Deborah Simon is the CEO of the Ontario Community Support Association. She is a registered nurse with a Bachelor of Arts from York University and an MBA from Athabasca University. Welcome, Deborah. Patrik Marier is a professor at Concordia University. His research focuses on the impact of aging populations on several public policy fields, including pensions, healthcare, and labor policy. Welcome, Patrik.
Welcome. Thank you for having me here.
Christine Kelly is an associate professor of community health sciences at the University of Manitoba. She is internationally recognized for her expertise on directly funded home care programs in Canada and is presently leading a study on the topic funded by the Canadian Institutes of Health Research. Hello, Christine.
Hi, everyone.
Wonderful. Now, before we get started, I want to just say to everyone as a note that you're going to have the chance to win a couple books today. We have one book here. This is Patrik's book called The Four Lenses of Population Aging. And we also have another book that I don't have with me. We're going to give away a copy of that. It's called The Aging Disability Nexus. It's co-edited by Christine Kelly. What you need to do is you need to stick around to the end of the webinar and fill out the survey. Then you'll be automatically entered in a draw to win either of the books. Now, before we get started today, what do we mean when we mention home care and talk about home care? It has many different narrow and wide definitions. However, the Canadian Home Care Association defines home care quite broadly as an array of services for people of all ages, provided in the home and in a community setting, encompassing health promotion, teaching, rehabilitation, support and maintenance, social adaptation, integration, and support for family caregivers. Now, our panel is going to present and discuss some of the issues and possibilities for expanding home care services across the provinces and territories. Each panelist will present in turn, and then, as Ricardo mentioned, we're going to have some time at the end for Q&As from the audience. Keep those questions short and pithy, and we'll get through as many as we can. So to get us started, Deborah will explain the breadth of issues facing care providers in Ontario in terms of providing home care services. So Deborah, over to you to kick us off.
Thank you so much. And hello, bonjour, everyone. I am very honored to be part of this panel. And I think I'll learn a lot this afternoon, as well as being able to hopefully share some of my thoughts. I'd like to start by saying that I'm speaking to you from my home in the city of Pickering, which resides on the land and treaty and traditional territories, of the Mississaugas and Scugog Islands and First Nation William Treaty signatories of the Mississauga and Chippewa nations. Pickering is also home to many Indigenous persons and communities who represent other diverse and distinct and autonomous Indigenous nations. This acknowledgement reminds us of our responsibility to our relationships with the First Peoples of Canada and to the ancestral lands on which we learn, share, work, and live. Getting started, I thought I would just share a couple of words about the association I work for in Ontario, the Ontario Community Support Association. We're about 30 years in age. As of next year, we're celebrating our 30th. We're made up of some legacy organizations, each one serving a component of home and community services. And back 30 years ago, they felt the need to have a stronger voice working together. Our association is made up of about 220 community governed not-for-profit organizations, and they're actually divided into three fairly large buckets of service types. There's home care, and there's community support, And there are independent living organizations which are part of the community support funding envelope here in Ontario. Just to give you a rough sense of our province, it's about 600,000 to 700,000 patients served by home care, roughly just about 1 million patients and clients rather served by community support. Under the home care umbrella, we're talking about over 9 million hours of nursing service, 35 million hours of personal care. Under the community support envelope, we are about 25 different programs, 3 million meals on wheels, over 1 million rides to transportation, 3 million hours of volunteers that help us do that. There's some pretty complex reporting lines here in Ontario. Home care now reports to a regional entity called the Home and Community Care Support Service entity, and the CSS folks are reporting into a new amalgamated structure called Ontario Health. So we are quite a complex sector in Ontario. So a part of the speak today was to really talk about what were some of the reasons that we felt that governments have not been spending in the area of home and community care. And I think we're all going to present some very differing thoughts. And I've divided my sort of thinking. There's probably a plethora of reasons why they haven't spent on home and community care, but just 5 big areas I thought I would share with all of you. The first one is really about home and community care itself. I mean, it is still a relatively new and broadly unknown sector to the general public. I think we all know the big H's in our communities where the hospitals are, and long-term care certainly has taken up a lot of space more recently, and people are more aware of that. But really, in the whole scheme of healthcare system, it was a large undertaking by government, at least in Ontario in the 90s, to really expand home support programs as well as professional services. And there was then a real proliferation of care that actually happened around the delivery of home and community care services. Albeit the service itself is not new, and we have organizations in our membership like BON who have been around well over 100 years delivering services in the community. But really, as a broader sector, I think for government, it has been one of those areas I think that is a little more obscure. And if obscurity is prevalent amongst home care, it is really even more so around community support services, as those services are pretty localized and their offerings differ in our province from community to community. There's a second area, I think, of interest maybe around how home and community care services have really evolved over the last 20 years. As hospitals started to take up shorter stays and less invasive procedures so that there could be more opportunity for recuperation in the community, home care services grew. But in that growth, there has been such an evolution of home and community care services over the last 2 decades. Care really now involves much more acute services. We are now delivering services like hemodialysis, ventilator care, complex wound care, and palliation, and all of these are more prolific in the community now. There's been more advanced practitioners come into home and community care, more direct workings with primary care and other service offerings in the community. And really, I feel for the most part, government decision makers have not been aware of the depth of the services that can be offered in community. The next area really of limitation, I think, in terms of spending and knowledge there has really been around sorry, I think I missed on my last slide 30, limited research and evidence on home and community care. And because the sector has been growing over the last couple of decades, we haven't had as much of the research interest and academic interest, although Christine will talk about a more recent research project, but the governments tend to respond to the evidence and research in terms of grounding their investments. And so I think from the perspective of home and community care, we've needed sort of more focus on that, less focus on institutional care, and more around the advancements that have happened in community. Around home and community care, the Canada Health Act, I think Patrik is going to speak more about this, but certainly the fact that home and community services are not covered under this act federally makes it even more challenging for governments in terms of their investment. Every province operates home and community care services very differently. Community services, for the most part, are not covered in some jurisdictions across Canada with government funding, and where there is funding, there is co-shares of fundraising and client fees involved. It makes it overall complex and not very well understood, and sort of contributes to that lack of understanding. And lastly, the competition for healthcare dollars. I mean, I think in Ontario, and it's not different from other provinces across the country, that healthcare dollars are stretched. And I throw up this slide to just show Ontario, but I don't think it's very different than other provinces where, the big spend is at the top at the hospitals and physician services, and then other programs kind of fall in line. The highlighted area with community programs really, third from the bottom behind mental health and other sort of capital spends. So with all of that, there have been obviously really clear barriers for the challenges for home and community care in Ontario, and certainly we're feeling that right now coming off the pandemic, and looking at recovery. We're starting to see right now, at least in our province, that some very limited investments right now in home and community care, and that may have a number of very specific issues in Ontario, but certainly we are still feeling the challenges of having had a very rough ride on the subsequent waves around long-term care, and so we're certainly having to push up interest in home and community care as a recovery for the country to move forward on. There is certainly a crisis in HHR, and that it's not only prevalent in home and community care services, but also with other sectors. We are losing healthcare practitioners and drives across all of healthcare. The fact that we've lost staff, over 3,000 nurses in home care in Ontario is certainly hurting us in terms of service delivery. And that is really related to the constraints on compensation in this province for our sector. We've lagged behind all the other sectors in terms of the funding for compensation. So that is really very much a challenge. We have modernization going on in Ontario, new legislation that came in that has had a significant, will be having significant impact. And that particularly on home and community care is really shaping up as we now move forward with regulatory changes in this province around the new legislation. So it will be an ongoing challenge. We have a very complex reporting structure, as I talked about at the very beginning, division of actually home care and community support services in terms of reporting lines, which makes it very complex for us. And in Ontario, we are in the process of a change towards a new structure under Ontario Health Teams. They are currently forming and storming in the province. And so there's going to be a need for more clarity around the integrated role for home and community care services. So this is just a bit of a flavor to home and community care from my perspective. And I'll throw it back to Colin.
Thank you very much, Deborah. That was a great tour de force to get us started. Patrik, who is also on the Indigenous lands of Tiohtià:ke, not far from our offices. Over to you, Patrik, your turn.
Thank you, Colin. So what I'm going to be presenting today is essentially one of the growing frustrations I've had with a lot of discussions surrounding home care policy, which is the underappreciated provincial diversity in home care. So if you're leaving the talk today, at least the lessons from my end that you get is that there is a wide diversity among the provinces. I can say I have done my job if I convince you that's the case. So The other title could have simply have been really the fallacy of the Canadian home care, because in fact, there is no such a thing as a Canadian home care. In fact, we have very different, 13 different home care frameworks throughout Canada. So let's start with the nice quote from Doug MacArthur, which pretty much tends to be forgotten, that the largest proportion of policy development, adaptation, and change is concentrated in the provincial sector. What's really interesting about home care is when you start thinking about it with regards to other policy area and how it has developed across the provinces, and to what extent it has not been, there hasn't been that much cooperation across the provinces and with the federal government. First off, so it is noticeably absent from federal framework. So it is an extended health service and the Canadian Health Act, which simply means that there are no federal standards and provinces can do as they please. There's also weak coordination at the federal level. For instance, when I talk with a lot of senior civil servants involved in home care, long-term care, and also more broadly, they would all quick to point out that in fact, they did not have a federal, provincial, territorial forum like they do in healthcare or with seniors. There is also nothing akin to the collaborations that we've seen in education, which is one other area that is very decentralized. But if you read, for instance, Jen Wallner's book on learning to school, it actually illustrates how provinces, despite this lack of strong federal involvement, succeeded in collaborating closely. And this is why we end up with very similar school system across the country. And also another point to emphasize, and that's the one I'm going to be discussing the most today, which is the fact that provinces now have had 50 years to develop their own unique policies and programs. So when you hear stories about, oh, now we're going to create federal standards, well, it ignores, in fact, that for half of a century, provinces have actually developed their own policies and programs in that field. So we have 10 provincial unique home care approaches, but all of them do display a heavy concentrations in long-term care spending in long-term care facilities. So in Quebec would be CHSLD, but interestingly, even the name of that actually changes quite a lot from one province to another. So I want to tackle three types of legacies that results in having very different home care systems in the country. So the first one has to do with home care policy and right-wing politics. So there is a strong link between having successive conservative governments and what I call in my book semi-comprehensive managed market, which is the case of Alberta and Ontario. So what's also very interesting from all of these reflections is the fact that Alberta has actually spent a lot of time and resources surrounding issues of population aging. And a lot of it had to do with the fact that Ed Stelmach, when he was premier, actually, he came from a very rural area, and that was an issue that was close to his heart. So when I conducted interviews in Alberta, a lot of the civil servants were well aware of the issues surrounding population aging, which at first glance might seem quite surprising because it is the youngest, relatively speaking, population in Canada. And it's clearly stated in the Alberta's Aging Population Policy Framework that was released, I think, 10 years ago. So individuals have primary responsibility for preparing for their senior years. This includes meeting their own basic needs and secure the resources they will require for their lifestyle they choose as they age. So aligned with a conservative politics, so the issues surrounding choice, personal responsibility is front and center in this model. And you have the same elements that happen in Ontario, and we forget now, especially in light of the recent events, in fact, that it was a highly polarized political issues. So in the late 1980s and the early 1990s, we actually had 3 home care reforms, right? There was one put forth by the Peterson government, the Liberal Party, and then the Ray government actually had their own home care reform as well. And then the one that is actually the most impactful that remains today is part of the common sense revolution of Mike Harris, which aimed to privatize the entire sector. That stands in stark contrast, for instance, with Quebec, that actually embraced more of a social economy model, and that especially the strong, and that leads to a strong involvement of social economy enterprises, especially in the field of home support. So there's a tax credit that supports it. And then the provinces offer some additional financial support to help these social enterprise to actually shoulder some of the administrative costs. So, and more, we've also seen that these social economy enterprise engage into contract with regional health authority, but there's a clear legacy now in Quebec that you have to involve the social economy, the community sector is organized as such into that field. Manitoba is also very interesting because it has more of a classic public service model, which has to do with the legacy of the NDP. So if you look back in time, so there was a commission of inquiry that was laid by non-health actors, and there was a strong involvement from the civil service at the time. And it remains to this day the oldest publicly funded home care program in Canada. So other provinces did introduce some sort of home care support, home care program, but it was not a publicly funded care program and as comprehensive as the one in Manitoba. So still to this day, you have a quasi-universal coverage. And of course, as many home care models, it has been under a lot of financial pressure, and there's been a lot of emphasis to find ways to increase the role of the market, but that legacy still remains. And what's also very interesting, if we go back to an old paper from an IRPP by Nina Chappell 10 years ago, she describes a big U-turn, privatization U-turn after years in the 1990s. So once they privatized, they realized it did not work and went back to a more public model. I want to also here add another type of legacy that's really discussed, which is the influence of career civil servants. So, and what's really interesting, if you think about this, so there's a whole literature in social policy that talks about the importance of having professional career civil servants and how it leads to actually policy that has a lot more foresight, and then as a result tends to be more robust through time. And a key illustration that I've done with my colleague, Chris Cooper, is to look at the development of home care in New Brunswick versus Nova Scotia, which is a province where there's a lot of patronage politics, where interest group gets to capture a lot of the politics. So in that case, in New Brunswick, it was really civil servants who came up with this idea of creating this extramural program, which is the Hospital Without Wall. And he succeeded in convincing the executive at the time to do so despite very strong pressure against it, most notably from the medical profession. And that legacy remains to this day because it is a program that is administered by a social development ministry. So that's the only province that is actually does not have home care in a health department, and that has a lot of important consequences. For instance, when we look at the first reaction to COVID response, so the social development ministry was part of the inner cabinet and actively involved, which is very strong contrast with what happened with our seniors minister in Quebec, for instance. It remains to this day the most generous with regards to the social dimensions of care. And when you do interview with civil servants, they clearly tell you, well, the seniors file is wrapped up with social services. So for them, there's no doubt that when you talk about seniors, you talk about social development ministry. I won't go through it because I'm running out of time. So Nova Scotia is a very late comer into home care and needed a provincial federal push. And in the paper, we show that it's really the last province that really got more invested in home care. So in conclusion here, I'll just pick a few because I've exceeded my time already, I apologize. So the first key issue, which is how to involve the federal government, right? As stated by a clerk of the Privy Council from one of the Atlantic provinces, everything begins and ends with healthcare. From the provincial perspectives, a lot of their issues and underfunding is directly related to the fact that the federal government has systematically underfunded healthcare, and its share of the healthcare funding has declined drastically, which actually has an impact throughout entire other programs. So within this kind of fiscal squeeze, it's very difficult to actually embark into other type of social policy. And then I want to also to emphasize the another element in the background that is really discussed, which is the accentuated biomedicalization of home care services. So not only we're seeing a squeeze in home care services, but we're seeing in terms a shift where in some cases we're talking literally about an abandonment of home support, and also a greater emphasis on rehabilitation services after short stay from hospital, as opposed to more traditional long-term care needs that tends to be pushed aside and receive less prioritization. So I'll stop with this. I'll be happy to take on your questions.
Thank you very much, Patrik. We do live in a wonderful federation indeed. And in fact, on that particular point, Christine, why don't you jump in and give us your presentation, which is also going to touch about the curious way that home care has evolved across the provinces.
Thank you so much. I'll put this up there. Do you see my presentation? So thanks, Colin, Jody, Clea, Ricardo, for having me here today. I'm presenting the role of directly funded home care on the Canadian home care landscape, and I'm here at the University of Manitoba. We are located on the original lands of the Anishinaabe, the Cree, Oji Cree, Dakota, and the Dene people, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories, and we acknowledge the harms and mistakes of the past and dedicate ourselves to moving forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. I also have to do some more throat clearing because you may have heard in the news that my university, our professors are on strike, and I am on strike and I'm very involved and supportive. I came right from a bargaining meeting to here. But we are allowed to maintain essential research activities such as this. If you're interested in the strike, you can contact me afterwards. And that's why I didn't use my university's template. That's my little protest. So there we go. So I've been studying this for a long time. So to wrap it up in 7 to 10 minutes is hard. But I want to talk about directly funded home care. So this is when people are given public funds to arrange their own home care services, basically cash for care. Most often it's actually a cash transfer, but there are cases where it's a budget, it's an amount, you're given a $700 budget. There's so many terms for it. And I'm sure everybody out there in outer space is in different provinces where you think, what's direct funding? But if you're in Ontario, you've probably heard that. But if you're in other provinces, you would have heard some of these other terms that are up on the screen here. One thing that's neat about this type of policy, and I think it's important to mention it because it helps explain a lot of why it is it has this very unique connection to disability rights movements. So you can picture like a young guys with physical disabilities demanding that they would have control over their services. We don't want nurses coming in. We don't want to be medicalized. Just give us the money and we will figure out what we're going to do, and we'll find people in our communities to work for us. So that history is there, even though this has really expanded. A lot of different populations are using it. A lot of older people are using this now, but that kind of history is underneath. In 2017 and 18, I put some citations here, but this is already dated. In 2017-18, we did an inventory of all the directly funded care programs in Canada. If you're looking at the map on the screen and you're seeing a lot of programs, it's because we were interested in the mechanism. So we also captured the individualized funding programs, which are programs for people with intellectual disabilities. Those are usually run through social ministries, family and social services, things like that, separate. But I know here we're primarily interested in home care. I totally agree with Patrik. It's really hard people ask me to be the Canadian researcher on things. I'm thinking, oh my God, it's so complicated. Can I just choose one province? One thing I will say, of the 20 programs, 10 are home care that we identified. What's similar across them? Well, they're provincial, with the exception of the Veterans Program, which is like a top-up program. They're administered by government or nonprofit. This is key for Canada. In Canada, directly funded home care is a niche population. It is a small proportion of our home care users. Other countries offering direct funded home care is the default, is the first offer. So that is not happening in Canada yet. It's not mainstream, with perhaps an exception here and there of Newfoundland. And also a thing in Canada that's pretty consistent is that you don't need to manage the money yourself. And why I would say that is because of that history of disability rights. There was a time, and there are some programs that really want the person themselves to manage and not a family member, an informal caregiver, but that's not really played out. There's some divergent issues across Canada, namely, can you hire family members with this money? Hot topic. There's also, can you use the money to hire a home care agency. That is not how this program usually works in other countries. So that's why that's kind of a bit of a muddy area in Canada. Since we did this inventory, Ontario launched another self-managed care program for targeted populations. Northwest Territories ran a pilot, and I was speaking to PEI earlier this year, helping them on developing their program. So there's a lot of interest in this. So people always ask me, like, is this going to solve our home care problems? And I can never give them a tidy answer, and I'm sorry for that. But when you're talking about pros and cons or strengths and weaknesses, who are you talking about? Who is this good for? So we have to think about the system, the paid caregivers. I'm so glad that Deborah's here to talk about that point of view. The caregivers, the unpaid caregivers, family and friends who are supporting, and then the person themselves, whether it's a person with a physical disability or an older adult who's using this program. So there's different strengths and weaknesses depending on who you're talking about. So from the client and caregiver perspective, and this is just a rapid overview, if you're using this type of program to find your own workers, it can be difficult to find workers. You may have trouble generating a backup plan if your worker is sick, and there is a noted administrative burden. There's more work required to be a self-managed home care user. For the care workers, there's some evidence that you can be fired without cause because, of course, you're working directly with a family rather than having another manager or layer in there. There's no place to report safety issues or if something goes wrong. It's really just you and the person on their own. Some of these issues can be sort of mitigated by this kind of option of using an agency, but then you get into questions of that the pay may be lower. So that's what happens there. The one thing that is so important when talking about this that cannot be overstated, I guess, is in a lot of studies in a lot of countries, people who use self-managed care prefer it. The families and the people themselves indicate a satisfaction. It's more flexible, it's empowering. Something we found is that it enables social rather than medical task shifting, so a more holistic scope of practice that is going on in the home. Allows for cultural, religious, and personal value matching. So I had stories of people being able to find someone who spoke the same language as their mom, or somebody who identified as lesbian and had a lot of judgment from the public home care providers, but she was able to hire someone who didn't care, didn't say anything. And sometimes hiring family members can be beneficial for people with dementia. For the workers, they do seem to prefer the more holistic scope of practice when you ask them about it. They like being able to do what's needed to be done and not have limits on what you can and can't do. They may have a higher hourly wage when you compare to working for an agency, but not always, and it's usually less than if there's a public provider in the province. There are not a lot of clear advantages. You know, I'm involved in a job action right now. There's not a lot of clear working conditions in that concrete way of benefits, security, all those types of things associated with using directly funded home care for the worker. For the system, well, we have that there's some risks here. There's some research that's saying it may exacerbate inequalities when you scale it up, when you start using it for more people. The outcomes are more established for younger people. So some of the research that's being used to justify it is not on the populations that are using it more and more. We need more research on health outcomes, not just satisfaction. Everyone always asks, well, are people just going to spend the money on whatever? No, they don't do that. So there's no evidence for that. When people need home care, then they need home care. So the money usually ends up, there was a little bit of a problem. I'm glad Patrik's here in Quebec for a while where the workers were being underpaid, but people still were buying care, and they did fix that problem through a payroll service. It undermines formal care worker education. So where you have in Ontario, they were trying to standardize the educational requirements. But then if you have this mechanism where people can hire whoever and there's no oversight, then it can kind of be in tension with that policy framework. In terms of strengths, it draws on a different pool of workers. In theory, that's a bit anecdotal. It may help serve rural areas. That's something often used to justify it. It's cost neutral. People used to say this, overstate this a little bit, that it was very cost effective, the cheapest way to do home care. But I think over time, we've seen it's more likely cost neutral. And it moves the system towards more individualized care, where really is a truly person-centered model going on here. So to close out, if you're, some things to watch for around this type of policy are worker wages and wage parity, because you can have situations like we do in Manitoba, where depending on if you're working for the public provider, an agency, or directly hired, your wage is completely different. Health equity, does it actually deliver in rural settings? Are people of lower socioeconomic backgrounds able to benefit? We found quite a bit in my research that it seems to be people of higher socioeconomic backgrounds using this. Should we hire family members? I have an opinion, but I'll leave it. This is kind of my own opinion, but I have an opinion on that. And about agencies, we can't get rid of home care agencies. That's ridiculous. But how can we help agencies deliver on the promises of DF Care? It's not supposed to just be a coupon. This isn't just supposed to be a way to help pay for your care. It's supposed to be a different model. So how can we help that kind of fall through the system while working through with the agencies? And then finally, strike a balance between a light touch and providing enough policy and administrative support to make sure that families aren't overburdened by this option. So I'll just leave it there, and I have some of my partners here, and here's my current research team up there. So thank you.
Thank you very much, Christine. I want to invite Patrik and Deborah to turn on their cameras too. We're going to start the discussion part of this webinar, and I'm going to also just remind everybody: get your questions in now. Make them short and on point, and we're going to try to get to them. But look, I have a few questions. Now, Christine, you did kind of tee me up there at the end. Now, I'm going to tease you out on that. I mean, most people, do get a significant, well, a lot of people get a significant amount of home care from their loved ones, and they do it in an informal way where they're not necessarily paid for it. So what does that mean? Does that mean, like, isn't it okay under a direct funded model for them to receive some kind of funding under that? I don't know. What do you think? You said you have an opinion, so let us know.
Well, the secondary function of a directly funded home care is respite. So if you end up paying somebody who's already living with you, you're not going to get the respite benefits. And caregivers are also an important health population, informal caregivers. They have their own health and financial issues. So my general kind of rule of thumb, it's very practical, but as long as they're not living with you, then I don't really see a big problem. Like the case of dementia, if you're able to hire a niece or a grandson who knows the person very well, it's going to enable for better care. But if you're living with them, we're not going to have the respite benefits that are part of this type of program.
Great. So the respite benefits matter then, and that should allow for the transferability to family members. That's
to a degree, with limits. That's what I'm saying. It should not be that just any family member can get the cash for this. It's really meant to find some outside support, and maybe there's some family members that would be appropriate.
Just to put a context, Colin, on Christine's comment, 80% of the care delivery and home care comes from caregivers. So, and the respite component is not a small undertaking. It's critically important.
That's great context, Deborah. And I also want to ask a question for context too, since you hit the point about the issues in hiring and retaining personnel. Tell us more about that. Tell us more about what the challenges are as you see them, as you're hearing. And at the same time, give us an idea as to sort of what policymakers should be doing to sort of proactively counteract those forces, whether it's just a question of compensation or it's other things.
Yeah, no, I think it's a really important. Thanks for the question. I think it's an important issue for us in terms of home care, and I can only speak really for Ontario. Maybe Patrik can speak to other provinces, but for frontline healthcare workers and other workers in the sector, for that matter, compensation is a big issue for them, and our sector has historically lagged behind other sectors in terms of compensation. So that situation has been ongoing for a long time now. But you take a crisis of sorts, this pandemic comes along, and now you've got shortages of healthcare workers across an entire continuum, and you further push the issue of compensation back on the burner for attracting staff to the sector. Now, how do you address it? I think Christine started to talk about it when she was talking about direct funding. Wage parity is pretty critical. Healthcare workers should have the option to decide where they want to work and shine in the areas that they really enjoy the most. And it's one of the things that we are really advocating strongly in our province. And I think that will definitely make a big difference. The other is really starting to do HHR planning, not in the silos of the distinct parts of the healthcare system like hospitals, long-term care, and home and community care, but really sort of cross sector healthcare planning so that unintended consequences of making a policy decision in one area of the sector doesn't have an impact on others.
Great, thanks. That's right. The issue of avoiding sort of the whack-a-mole problem in addressing healthcare policies and policy solutions is a big one. Look, I'm going to start to take some questions from the audience because we've got a lot of good ones. So I'm just going to move there right away. And Patrik, you're up. One of these questions points to the $10 a day daycare template for stimulating and provoking provincial governments to perhaps get on board. Now, what do you think? Could such a model, be used potentially to provoke policy change in home care? And since you're based in Quebec, I mean, would Quebec be up for something like that? What do you think?
Well, it would definitely be a good idea to move forward. But what was clear from all my interviews with senior civil servants, all of this is really wrapped up with the healthcare funding issue. So when you go from 50% to 22%, that has had major consequences. And then you've cut a lot of the services and home care. Whenever there are big recessions, usually home care is the hardest hit. And then it takes much longer to actually reestablish funding in home care than you do, for example, in hospital. And I think part of the problem is how this element is also interlooped with healthcare to begin with, which we rarely talk about in Canada, right? So at the end of the day, you have regional health authorities that are managed primarily by individuals who are hospital managers. So home care for them is a very far away responsibilities and priorities. And in the sense that if you don't boost your healthcare spending within that framework, it's very difficult to ensure that the money will trickle down. So the federal government can go to the table and maybe engage in negotiation to maybe reestablish more healthcare funding, with some of it devoted to home care. But I think the key issues in terms of negotiation is that what are going to be the condition and the standards. So in many ways, they're so different and they are embedded in such different histories. At the end of the day, it would be very difficult to actually establish something where the federal government can say, see, because I intervene, now we have better standards, without alienating the province, especially like I have a lovely quote from Premier Higgs in New Brunswick. He says, well, I don't want a federal deal when I have to take Ontario's standards and import this in our province, because the way we do things in our province work well.
Thanks, Patrik. Okay, I have another question, and maybe we can sort of very quickly get some answers out of everyone on this, because I think it's an important one. So the question is would it be useful for Canadian provinces to draw a clear distinction between home care in the form of health services and home care in terms of social care as done in the UK? So the distinction being that healthcare service would be things like help with toileting, with dressing, with potential healthcare treatments, and then social services, social home care services are things like, well, potentially help with food preparation, laundry, and even something simple like shoveling the sidewalk. So, Christine, starting with you, what do you think? Do you think that distinction is important? And in terms of the value of that distinction, do you think we should be publicly funding both forms of home care services, social and healthcare, or should we be focusing our efforts just on funding healthcare services that are delivered at the home? So, Christine, get us started.
Well, a lot of provinces and individual places will have a distinction with two different pay grades, and I'm sure people know that, where they'll have one term, there's many terms that refer to the more medical, usually one who's done some training, and one that's more social. But I actually think it's better when it's together, and I'm thinking of some of the Scandinavian countries where we have such strong outcomes, and it's because the workers are not constrained. They're not saying 15 minutes for a bath, and then we need another worker to come in and help with the shopping. Like, that doesn't lead to person-centered care. It doesn't, it drives people towards institutionalization because it becomes unsustainable. And these workers like to do what needs to be done if there's some, limits. We don't want it to go to the end of the earth, but I actually think it's better to really understand that helping someone is a completely holistic social and health intervention. And we shouldn't be shy that that's what's keeping people in their homes, is being able to help with these things that are not just the bathing and the dressing, but this other part that really can make or break whether you need to go into residential care. So that's kind of where I stand. I think it should be together, and I think we shouldn't be so shy about it. It should be part of the home care system.
Can I just jump in on that? And Christine, I couldn't agree more. It's clearly from the perspective of our own association that we speak about home and community care. We don't talk only about home care or only about community support. They are best when they are both in place. And it is a bit, Colin, like going back to the future, because, when Patrik talked about the 50-year history of home care, it initially started that way. It started as the provision of home care, whatever medical services might have been needed, but also really the strong component of home support. And in Ontario, when they did one form of the predecessor to Ontario Health Teams through Health Links, they found that part of the challenge in delivering community-based services was that there wasn't enough integration of social services with healthcare to be able to deliver on what people needed, particularly care in the community. So I think they are intrinsically connected and should not be divided. The whole issue of funding it is another portion of that. And in Ontario, not all of the home support services are 100% funded. In cases of equity, socioeconomic concerns, they should be 100% funded. But it isn't that they are currently. So that's kind of my thought.
If I could just get you to hold on for 1 second, because I have a question coming in specifically to Deborah on this point. It's, in Ontario, how does it work? Are the monies given to agencies, or how does the government fund the agencies, and how does it oversee them? Don't worry, Patrik, I'm going to give you a chance to come in on that one. But I just
So I think IRPP will pay me for another hour to explain the complexity in Ontario funding, but let me just say that they are private agencies are funded through a third-party provider. And in the case of home support right now, it's being funded through an entity called Ontario Health, which is a provincial regional organization. And home care is now funded through another structure in Ontario. So it is that they are private organizations and entities, but that is public dollars that are funded through those organizations.
Thanks. Patrik, health and social home care. Care to take a different tack than Christine and Deborah? What do you think?
Well, actually, I'm not going to do that. So in fact, I would say, politically speaking, what we see right now is the way this split is used politically to actually justify concentrating your home care dollars straight more on the more medical type of services. And that's at the expense of home support, while at the same time having this nice feel on social determinants of health. So if you do this, you're just reinforcing this. And there's a lot of literature that shows in the end, these social elements needs to be better integrated. And if you actually disjoin them, you marginalize them further.
Thanks, Patrik. We're getting lots of questions when it comes to the direct funding model. No surprise. But Christine, tell us, what does the research say about any impacts of direct funding on quality of care vis-a-vis those who would otherwise potentially receive publicly provided care? You know, at the same time, there's the question of like, okay, well, if you were to suggest to governments that were interested in expanding their direct funding models, what would you suggest to them to potentially counter some of the downsides to it? So 2 questions there.
Thanks. Yeah. One of the problems is that there was a huge like clinical controlled trial in the United States, but they were comparing people using agencies with people finding someone and hiring them on their own. Whereas in Canada, we have this complicated, we've got the public, we have the agencies, and then we have people hiring directly. But putting that aside, in the States, they found hands down, very, very clear results that people did better under directly funded care. Health, social, satisfaction, all of these different things. When we come back to Canada, I've asked myself sometimes if we just fixed public home care to not be so medicalized and incrementalized and task-based, would direct funding be as popular? And I'm not sure, but like there is some lessons we can learn from direct funding to bring over to regular home care. So, but we don't have Canadian research that's clearly comparing those 3 different scenarios. In terms of expanding it, I would just say, like when I was talking to PEI, who I don't know if they're here in this big room, but like just kind of proceed with confidence, because there's a lot of research. This is very well established, especially for people with physical disabilities, extremely well established. There's no, you know, go for it. But it's not a silver bullet. Like you can't just put it in and we'll automatically going to have these great outcomes. You have to think about the kind of administrative support for people and kind of backup and, you know, just different decisions around all these different points to make sure that it really is delivering on its promises. But, you know, you'll run one of these pilots or something like that, and you'll hear from everyone using it how much they like it. Now, talk to the workers, I don't know. So we'll see. That's why I can never give like a clear, you know, this is the best thing in the world, but it's certainly, we can learn things from it for sure. And you can't dismiss that people really like it, because that's important.
That's probably why we're getting so many questions on it too.
Yeah, I know.
It's curiosity.
Yeah.
Question, Deborah, and then I've got one for Patrik after. You mentioned respite care and the amount of care that families provide. How do you think that governments can best support families that do so much home care, either financially or otherwise?
Yeah, it's a great question. Thanks. And I think that what we forget when we're funding services is that, particularly on the home care front, that these services are just a fraction of the 24 hours that people require care. And, you know, the way to improve the ability to have strong, good services in home and community care is to make sure that there's care for the caregiver. And that has been a program that has actually obviously suffered much when there are cutbacks in funding from government, because they're not as visible to them as paid workers are, for instance. So, I mean, I think the build into home care, for sure, home and community care, has got to be that you've got some kind of partnering respite program that can support people. And we have in Ontario great resources now building up. We've got the Ontario Caregiver Association that's in place, and they're starting to look at linking support services across just delivery sectors, like both, you know, people who are sort of disease specific supports and home care. So accessing those services have got to be really, really easy for people, because they will not partake of programs that are really difficult to find and you know, challenging to implement in their own areas. But respite has got to be as important as the actual dollar funding of any program in home and community care.
Thank you, Deborah. And the question for Patrik. You've mentioned, you know, the challenges of potentially using a model like being rolled out across Canada right now for childcare as something that would apply for home care. But if you were in the room right now with the Minister of Health, so with Jean-Yves Duclos, and you were telling him, you're saying, okay, here's what I think the federal government should be doing or thinking about doing in the area of home care. You know, where they've signed some bilaterals in the last few years too. Like, what would you be suggesting that the federal government do, and how to engage the provinces?
Well, I think it has to be engaged with part of a broader discussion on healthcare, but also making sure that you keep provide funding to actually maintain these provincial specificities and bonify them. And at the end of the day, there's still room for provincial politics, right? So people living in these provinces have voted for governments that enacted programs that reflect some of the political preferences in these provinces. And I think these should be taken into account, especially if you want this kind of agreement to actually work over time. So you don't want this to be undone by the next minister, which is part of a major issue in home care because it's so not well institutionalized, right? The ebbs of flow in politics has a major impact. And the other thing I would say that even further to that is that, you know, I give you a quick snapshot across each of the provinces, but I could go within each of these provinces and talk about how difficult or how maybe underline the negative impacts of provincial standards as well. So I've traveled into a lot of rural regions when you talk about home care, and it's a way different reality than being in downtown Montreal. So in some cases, you know, the long-term care facilities is 100, 120 kilometers away from the city. So if people want to remain in their community, they need a lot more flexibility with the way we organize and provide home care than they do in and let's say a regional city that has a long-term care facility nearby.
Patrik, I've got one last question, and then we're going to try to give everyone a chance to answer. So the question is, what are the thoughts on the panelists to the panelists on the overall role of home care in the broader continuum of care? Is home care underfunded? And to the extent that we could increase funding towards home care, do you think that would help alleviate some of the demand for care in long-term care homes? So it's two-part question. I'll start with you, Christine, and then we'll just go around and give everybody a chance to answer. So what do you think? Is home care underfunded? What can we do to get more funding towards home care?
I do think home care is underfunded, and I think shifting some of the resources from long-term care to home care is needed. And we seem to be at a time where people are more willing to hear that, where other times it was a bit controversial to say something like that. So, you know, I think we need to shift some of that. And one thing we can do that we haven't really mentioned, but we kind of danced around it here and there, we really do have to pay the workers quite well. Make this a very desirable job, because people, a lot of times they leave because they're not paid enough, not because they don't like it. So I think that there's things we can do that are very sort of concrete if we just increase the wages, and this thing we talked about earlier about not kind of handcuffing people to only doing medical tasks, because that's not going to have a very person-centered type of care. So yeah, I think we need to redirect from long-term care.
Deborah?
Yeah. Absolutely, home and community care is underfunded, and I think you've seen the slide that I threw up in terms of the spend, and certainly in Ontario, in terms of you know, where the dollar has to go, and the sliver of the pie that actually goes to home and community care services is still very small. And then what governments I think really need to start looking at, and I think Patrik had started to talk about it in his slide deck, is really a home first philosophy. Clearly coming out of this pandemic, people have really come to appreciate, certainly those who are awaiting long-term care services, the ability to receive services in their communities, in their homes where they feel safest and where it is possible to deliver high quality care. And so we need to start to continue to push on shifting that sliver of the overall spend more towards home and community, so that individuals, Canadians, you know, loudly stated in every survey that that's where they want to receive the services. To do that shift is challenging. I mean, our overall spend on healthcare is high across all of Canada, and so we can't simply take money from hospitals and take money from physicians and just throw it at home care. It just does definitely need to have a much more integrated and strategic approach to trying to build home and community care services to be a bigger piece of the pie. And so, yeah, for sure, I think that is a direction that we should be looking at. And there's other jurisdictions that have done this very successfully.
Yeah. If I can add to this, right, this is, if I'm going to reshare my screen again quickly, you know, this is when you think about provincial priority, you get that. And I can tell you every single civil servant, right? So The book was about how to plan for population aging. By far and away, home care is the most popular and most consensual policy that you've got. However, if you look at our budget spending on the left here, you see that only 11% of all our long-term care funding goes to home care, which is ridiculous. It does not reflect, it's totally disconnected from the policy priorities we had in the past 20 years. And we're very far away from, for example, the Finnish model, which is literally the other way around, where 80% is in home care and only 20% institutional, even Denmark, if you look at it. And I think we need to have a debate that goes even broader than that if we go back and we think about the fact that we are now in an aging society, right? We need to ensure that we mobilize as many people as possible in the labor force. And you're not going to be able to do that if you don't have good home care. And it also has other consequences when we think about gender dynamic, right? So we do have a lot of policy objectives that want to have equal pay for, equal pay. And at the end of the day, you're not going to have that if we're going to have to start turning back the clock, because people are going to start refusing promotions, are going to take less hours in the labor market. And the literature shows that the vast majority of individuals who do these choices tend to be women.
Thanks, Patrik. That was the final word. Look, we have so many amazing questions. Like, we really could just keep going and going and going. But probably it's a sign that maybe we should just all come back here one day and finish this discussion. So I want to thank everyone. Thanks, Deborah. Thanks, Christine. Thanks, Patrik, for being here. We're going to try to store some of these questions and maybe pass them along after the webinar. And for those of you who are still with us, fill out the survey at the end. You'll get a chance to leave your email address. We've got books, we've got information. It's yours. Feel free to get informed. And thanks to everyone. Thanks to my colleagues for helping put this on. And we'll see you all next time. Thanks so much for being with us today.